Welcome to the show. I'm your host, Dr. Ronald Yap. Today we'll be talking about prostate cancer. Dr. Ami Kilchevsky from Concord Urology joins me for this episode. Prostate cancer is the most common non-skin cancer in men and is the second leading cause of cancer death in men. 1 in 7 men will be diagnosed with this disease in his lifetime. If you're African American, the odds go up to 1 in 5. If you have a family history, it's 1 in 3. Men with prostate cancer have many options to address the disease. Management options include surveillance, observation, surgery, and radiation-based procedures such as beam radiation and seeds. On the previous show, it's the pilot episode, so please tune into that. We did an overview over radiation-based procedures with Dr. Tom Sheldon. Today we'll discuss the diagnosis, surveillance strategies, and surgical management. In this two-part episode. It's a lot of content. So first, intro about Dr. Kilchevsky. He's a partner from Concord Urology, joined us in 2016. Undergraduate degree in international politics and economics from Middlebury College. Medical doctorate from George Washington University. Urology training at Yale University Medical Center. And fellowship in urologic oncology at the National Cancer Institute in Bethesda. All-around awesome dude. And happy to have him here joining our group, specializing in urologic cancer care. So what'd you think about intro, man?
That was good.
Yeah, we pumped you up, man.
Yeah, I did. Yeah, it's a lot to live up to. To live up to.
But give me a little flavor. Tell me about yourself. You know, coming to Concord and joining us, and then we'll dive into the subject matter.
Sure. Well, first, thanks for the really kind introduction. I always tell patients, family members, ask how the heck I ended up in New Hampshire, that this is a hospital that packs way more of a punch than what you would expect for being in a relatively small town in New England. We were drawn, my wife and I were drawn to the Northeast because we had lived in New Haven, Connecticut for many years, and I'm from Connecticut originally, and always enjoyed being in the Northeast. We had looked all over the country, and I just found that the partners, yourself included, at Concord Urology were fantastic. Dr. Sheldon, who had been in a previous episode, and other members of the hospital staff were just really very academically inclined. We have residents that work with us at Concord Hospital. We have really some of the top trained physicians, I would argue, in the country. And we were just drawn to being in a community that we could not only live in, but also take care of. And that's what ultimately brought us to New Hampshire. We've been ecstatic. We had a great summer and enjoyed our winter so far. And it's been really a fun 6 months.
That's great.
6 months, yeah.
That's great. So we're keeping you busy.
Keeping me very busy.
That's
very busy, which is good.
That's
busy
cool.
is good.
Well, I'm just so happy to have you here. I mean, there's so much. You know, we talked about the stats here with prostate cancer. A lot of guys out there need help.
Yeah, people, I think one of the most common things that I tell patients when I first go over a diagnosis with prostate cancer is that they're not alone, that there are a lot of men out there who are diagnosed with prostate cancer. Men don't realize that they're going through a very traumatic point in their lives, but they have other men out there who are also going through it or have been through it and can support them. It is a very commonly diagnosed prostate cancer. Prostate cancer is a very commonly diagnosed disease in the United States. Every year, about 160,000 men will be diagnosed with prostate cancer. And like I just said, that they need to know that there's a support system out there. That you and I are, have essentially open hours, and we're happy to talk to these men as they're going through a very trying time in their lives. But it's a very important disease that we need to really talk about, and I'm glad that you're doing a show to get this knowledge out there.
I think that could be a good point for a plug for our man-to-man support group.
Yes.
So there's so many guys dealing with this in our community. I think we have the most active group by number, but at Concord Hospital at our patient center, men get together as they're going through the decision-making process, in the middle of treatment and after treatment. There's free food too, so you got to show up for that. But awesome speakers. We go to the meetings, and a good group of guys. So for guys that are afflicted by this out there, wherever you're seeing this, be it Concord TV or out on the internet, it's a resource. And not just for Concord Hospital patients. There are people that don't even have care at our institution that actually come. It's one of the most active groups in the state.
Mm-hmm. Yeah, it's men who have had treatments, who are deciding what treatment to get. It's the second Wednesday of every month over in the patient center. So I strongly encourage all my patients and anybody who's watching this to bring their significant others along and meet with other men who are going through the same thing that they are.
Yeah, awesome point. A spouse is welcome, and everybody's different. I don't want to get off too much on it because we got on a good riff on this, but I think one thing you mentioned, it's such an important disease, but everybody deals with it in their own way. Some people they clam up, they want to do it analytically with their doctor in private, and some people want to get out there and share, and they kind of crowdsource their treatment, so it's a good option.
Yes.
So, all right, so let's dive into the subject matter. So number one, so I guess how does a man get to the point where they're sitting across from us? It never gets easy, does it, Ami? I mean, we sit there with that report, and
Right.
it changes people's lives. Tell me a bit about, we could have a whole show just about, the controversy of it, but when they get to the biopsy, tell me a bit about the screening part. How is it diagnosed nowadays? How do we even get in this situation?
Sure. So all men have prostates. Women do not have prostates. Men have a gland in their pelvis that secretes fluid that helps with ejaculation. So it plays a very important role in the reproductive process. The prostate is essentially an organ that continues to grow with age. Any organ that grows with time can develop a cancer. Cancer is just an abnormal growth, and the more rapidly any cell is turning over, the more likely it is that that cell can develop a cancer. So as men age and as their prostates continue to grow, they can develop urinary symptoms. So a lot of our practice is dealing with men and urinary symptoms. But as a corollary to that, a lot of men can also develop prostate cancer because of the rapid rate of growth of their prostate. The American Urologic Guidelines, which kind of dictate the way we practice, would have you perform prostate-specific antigen tests, which are blood tests that men over the age of 55 are recommended to get on an annual basis after a discussion with their primary doctor or urologist. And they would get an annual screening with that PSA, which is a protein that is secreted only by the prostate, in addition to a digital rectal exam. If the prostate-specific antigen is elevated, or there's an abnormality felt on a digital rectal exam, that could prompt a urologist to perform a biopsy, which is done by inserting an ultrasound probe in the rectum and taking 12 discrete biopsies of the prostate. As I had mentioned, that is unfortunately what we end up using to diagnose men with prostate cancer. So elevated PSA or abnormal prostate exam would prompt a urologist to recommend a biopsy, which then would allow us to make the diagnosis of prostate cancer.
That's a great summary. I can tell you, too, we could spend innumerable hours talking about this controversy. And I think the bottom line for the community, patients out there, is just talk to your doctor. And urologists project, we look at expected longevity, essentially, where if you are anticipated to have a 10 or so year longevity, then have that discussion. The American Urological Society is for screening for the appropriately selected men, understanding that the PSA test is a test, but admittedly imperfect test. And we just had the Super Bowl, so oh, sorry, I can't even go there because you're not a Pats fan.
No, I don't want to say that. I'm going to lose all my audience.
Oh man,
now.
you're on my
That's
show.
It, everyone's gone.
But
yeah.
oh boy, I think I just torpedoed your show. But
Go Buffalo.
The Pats won,
sorry.
man, and it was awesome. But the reason why I bring that up is it was an awesome comeback, first of all. But aside from that, the American Urological Association has a wonderful campaign with Mike Haynes, Hall of Famer, called Know Your Stats. Big proponents of screening. They were there. I've been watching it on social media. And shout out to the Urology Care Foundation and their efforts, because aside from who won and lost the Super Bowl, there were a lot of dudes watching it. The awareness should be there. And basically, we just say get in and have that conversation with your doctor, urologist, and figure it out if it's for you. But like you mentioned, when you get down to a biopsy and screening, when you get that diagnosis, what type of characteristics do you look at? You get that report, and I think when a patient comes in to see us, they just say, oh man, doctor told me I have prostate cancer. Can you give us some details, a little flavor as, what do you look at in that report? What characteristics do you see in the patient that help you present your options to the patient?
Sure. So we grade prostate cancer on a scale of 6 to 10. The score itself that we use to grade is called the Gleason grading score. The level 6 would be considered a very, very low risk type of prostate cancer, whereas a 10 would be considered a very high grade prostate cancer. What we look at is the volume of cancer, so how much cancer a patient may have, and that would be measured in the percent of each specimen that we take, and what type of cancer they have. So a male that might have one core of a Gleason 6 prostate cancer may be a candidate for treatment options or no treatment options, whereas a patient with a high volume of a Gleason 9 or a 10, which is a high grade cancer, would have a very different treatment approach. So I think that it's very important to know that not all prostate cancer is equal, and that there are some cancers that we will observe and not actively treat, and there are some cancers that we recommend very aggressive treatment, and maybe even multimodal treatment, as I'm sure we'll get into, not only with surgical options, but also perhaps even with radiation options as well.
Sure, and in addition to that pathology, tell me a bit about more, when you have the higher grade disease, any other testing you do for those types of people versus the lower grade diseases?
So there are additional tests. If a patient does have a high grade prostate cancer, which, as I said, would be considered anything above a Gleason 8, then I would recommend proceeding with a metastatic workup. Unfortunately, we know that men who have high grade prostate cancers are more likely to develop metastatic disease at presentation. So in order to ensure that they don't have metastatic disease, I would recommend getting a CAT scan of the pelvis, which means that we would look from about the middle of the belly down to make sure that there's no enlarged lymph nodes. And we would also then get a bone scan because, unfortunately, prostate cancer has a very high propensity of attacking bone cells. So there's a good chance that if a patient has a very high-grade prostate cancer or a very elevated PSA, that we are worried about disease spreading to the bone. So when a patient comes in with a PSA greater than 20 or a Gleason score of 8 or above, the first thing I would do before even getting into the discussion about what treatment options are available is to make sure that they've had a bone scan and a CT scan or an MRI of the pelvis.
I see. And you brought up MRI, so out of your fellowship at the NCI, I know you were a big center for the use of MRI, and this is something that's starting to really catch fire in the urological community, not only on the diagnosis part, but perhaps in some cases in the staging part. Any thoughts in your mind, just coming from that program? Where are we at with that, and what do you think it could offer, in that initial phase when you're diagnosing people?
Absolutely, I think that's a great question. I hope we have another couple hours for me to talk about MRI and prostate cancer.
If you don't bring up the bills, we may let you come back, buddy.
I already did once. That's my quota. That was my quota for today. It's still a sore spot, but no, I respect the Patriots. I just am jealous, that's all. So one thing that is now being very widely used in the prostate cancer community is MRIs. And one thing that I'm very proud about Concord Hospital for working on is actually bringing the MRI technology to the patients, to the community here in Concord, and I think that's very important. It's very cutting edge, and quite honestly, it's the future. It might not even be the future, it's now, and we're doing it, and we're really staying very active on top of MRI for prostate cancer. So prostate cancer can be used in a number of ways. It can be used not only for screening, but also for diagnosis in terms of allowing us to more accurately biopsy, which I'll get into, but also for surgical planning. Some people use an MRI prior to surgery to better ascertain where tumor may be, and in so doing allow us to perhaps alter our surgical approach. Now, I know in the second part we're going to get into surgery, but to talk about MRI for screening for prostate cancer, some men have an elevated PSA, but we are still unable to find any prostate cancer on a transrectal ultrasound with biopsy. What a lot of men don't realize is that and feel free to interject, but with an ultrasound, we're not actually able to identify any specific lesions in the prostate. An ultrasound is a fantastic tool to allow us to see the prostate, to measure the prostate, to gauge where our biopsy needles are going. But one thing that's not commonly understood is that an ultrasound does not actually find any sort of prostate cancer unless it's a very progressed prostate cancer that's very large and is distorting the actual contour of the prostate. So enter the MRI, which a lot of the researchers down initially in the National Cancer Institute in Bethesda, Maryland, discovered was that they can actually use MRI and find lesions that were hidden that way. They subsequently developed a computer program that allows the MRI to interface with the ultrasound that can be done in the office or the operating room, and allows the urologist, and allows you and I to be able to more specifically target any lesion in question. So it's a very, very accurate way of diagnosing prostate cancer. It allows us to find cancers that previously were missed and that some patients unfortunately went untreated because we were unable to find the cancers in question. So the MRI is now becoming a very widely used tool to find prostate cancers, and it's something that we at Concord Hospital are starting to work on, and we're We will be the only center in essentially Maine, Vermont, New Hampshire that offers this sort of technology. So we're very excited to be bringing that here, and it's coming very soon.
Thanks for that overview, and it was a really great summary. And I think the one thing we're dealing with and why screening has been, poo-pooed in the community is that, oh boy, this test is elevated, this lab test, and you get this painful transrectal biopsy, and the stats are, about 1 million biopsies done in America annually, for which there are about 250,000 positive, diagnoses. So the yield from the screening with the transrectal ultrasound biopsies, isn't the best. It's a sampling, but in certain cases, the MRI can be very helpful. And I think we both have patients in our practice where we've had negative biopsy, the PSA keeps rising. That biopsy only can access the part that's facing the rectum, mm-hmm. So there are some funky tumors that appear in other spots like the top, and you can't possibly access right. that. So it gives you a bigger view of the playing field,
Absolutely. So. Yeah, historically people have actually thought that there were certain parts of the prostate, like in the center of the prostate, that weren't susceptible to develop cancer. However, with the advent and widespread use of MRIs and targeted biopsies, we're finding that almost 25% of cancers are actually harbored in places that historically urologists felt cancer wasn't found. So I think this, we measure prostate cancer survival on the order of decades, not weeks, months, years, so it's very hard to have long-term data because this is a relatively new technology, but I suspect as we move out, prostate MRIs have been around since about 2008, 2009, so we're not quite at that 10-year mark, but I suspect if we look in the future, we'll find that actually, I do truly believe that survival will improve with the widespread use of MRIs for prostate cancer screening.
And I think you need time to build up that expertise because Absolutely. We are incredibly reliant upon appropriate high-fidelity radiology, reads on these. Mm-hmm. And hats off to the Concord Hospital radiologists where they were open-minded, tackled it. More people are getting trained up in it, and they see the future. And they know that the biopsy, in and of itself, sometimes people started now calling them blind biopsies because essentially you're looking for mm-hmm. a lesion with the ultrasound, and most of the time, like you mentioned, you can't really find it, and the MRI adds a lot to that. As we're talking about newer ways to diagnose, I think we're on a good trend here talking about newer technologies. The concept of newer biomarkers come up, and I'm talking about the prostate health index or 4K score. Any thoughts in your mind about how would you use that as far as finding the aggressive disease, less aggressive disease, and improving that utility? Because like we said, a lot of guys get PSAs. Not everybody is prostate cancer. A lot of the mantra now is how do we reduce the harms of the screening and improve the benefits?
Mm-hmm. So I think that is also a very important point that you bring up. It's something that has been done in conjunction with screening tools such as MRIs, but using other blood tests such as a 4K score, it allows the urologist to actually obtain a percent chance that their patient may harbor an intermediate or high-risk prostate cancer. It's essentially doing what an MRI is doing, but via a blood test. So in other words, it is telling us not necessarily that a patient does definitively have prostate cancer, but if there's a patient that their PSA has been teetering on the edge of normal and you're a little bit concerned because they may have a positive family history, there is a blood test that can be done, which is a little bit more involved than a PSA. The actual blood test itself is not much more involved, but the workup of that blood is more involved, and it allows the pathologist and for us to have a better idea of what percent chance that patient may have prostate cancer. Now, again, it's only a screening tool, so much like PSA, it does not tell us for sure that a patient will or will not have prostate cancer, but it is a good screening tool for a patient who may be on the edge, may be hesitant to proceed with the biopsy, because there are risks associated with any sort of intervention. Risks of a biopsy are bleeding or pain, and most notably infection, which while the risk is low, less than 1%, it is not zero. And if you're the patient who does become sick after getting a biopsy, then it's certainly a very significant event. But things like a 4K score are important. There are also other types of screening tools that we can use that actually look at the tissue itself. So there's something called Oncotype DX, which is a genetic marker that is used based on the actual tissue pathology obtained at the time of biopsy. It's a send-away test, so it's not a test that's done here at Concord or at most institutions. And what it allows us as urologists to do is to say, if we get a patient who has a relatively low-grade prostate cancer, and they have a very high score on their Oncotype DX that's concerning that they may actually be harboring a more aggressive cancer than what their pathology is letting on to, then we may offer them different treatment options. So there are a lot of biomarkers, there are a lot of genetic testing. I think truly the future of prostate cancer screening is genetic testing. I think that's the future of a lot of screening, and it's already being used for things like breast and ovarian cancer, where women who might have a strong family history might be getting BRCA testing, for example, at an earlier age, and then making treatment decisions based on those values. So I think that prostate cancer is going in a very similar route.
Mm-hmm. And yeah, I can echo those concerns about that family history. Is if you really do have that family history, that does increase your odds. So take that seriously and get screened earlier. We say, starting at the age of 40-ish, if you're a family history, you're African American, or there are some people that I've seen out there where they even have very early onset prostate cancer. And in my training at Northwestern, we even have taken out prostates in people as young as 32, actually, is the youngest guy, because that person had a family history, and that person's father had early onset. He got screened 10 years less than the age of that person, which was when he had it in his 40s, and he had a prostatectomy at the age of 32, and he did fantastic. So I think this is a great time to wrap it up, because I'm getting waved from Chris out there in the booth. So I think we covered a lot of great ground today. We introed you to the community. We talked about the Super Bowl. We talked about screening principles, and we'll wrap this up. And thanks for joining me, Dr. Kilchevsky, and then we'll pick it up for part 2, and we'll dive into what do you do next. We're going to talk about surveillance strategies, be it watchful waiting or active surveillance, and then we'll talk about prostatectomy, which I think is going to get Ami really excited here. So we'll get that going. So I guess you can take a bathroom break and then come back for part 2. And thanks much again.
Absolutely.
Dr. Kilchevsky.
Thank you for having me.